Okay, so now we're going to talk about some clinical profiles. Dr. Mickey Collins is going to rejoin us, and we're also going to be joined for the first time today by Aoife McMahon, who's a physio with Bon Secours Health System.
Okay, we thought we would present some cases that kind of put this clinical profile model into action, and we're going to make up a little time here, I think, to get back on track and get through the cases pretty quickly. But I think I have 2 cases to present, and then Aoife has 1 case to present. And it would just start to put this, the rubber meets the road when we see our patients, and I wanted to go through and present to you some simple cases that kind of explain things. So I'm going to show a case of a college hockey player. You guys know what hockey is, right? I hope. Is there hockey played in Ireland or not really? Yeah, I have 2 ice hockey cases I'm going to present, just ironically. So it's rare, yeah. All right. So here is a college hockey player. This is a 19-year-old male. You're going to see in a video here in the next slide where he was skating to the boards and then got hit from behind, struck his head off the boards, falls back, hits his head off the ice. This individual has, and when we look at concussion, we always want to look at relevant medical history. There's no risk factors. He has no history of car sickness, no history of lazy eye, no problems with anxiety. Very well-adjusted kid. He's a 3.7 on a 4.0 scale grade point average. So he's a really smart kid majoring in engineering at the U.S. Naval Academy, which is a very elite institution. It's hard. You have to have a senator's recommendation to get into this school. They train for the Navy, but he's also one of the country's leading hockey players. They have a national award every year, and he was a finalist for the award as a 19-year-old, and they actually have a pretty good hockey team at the Naval Academy. So this is a high-level student, high-level athlete. He's going to play in the NHL at some point. I mean, there's a lot at stake for this kid. But I'm going to show you the video of his hit. If you can play the video, you're going to watch over here. If you can play the video again. And just, if you think about the forces involved in this injury, it's pretty impressive. You think about, there's 2 blows here, really. Head against board, head against ice. And it's very dangerous when that first hit against the board knocks him unconscious and then he lands unprotected on the ice. And the ice is a very unforgiving surface. I don't care what hockey players wear helmets. I don't care what you're wearing around your head there. The brain movement inside the skull is what causes the stretching of the neuron, release of potassium, influx of calcium, and that results in that energy process. There was a brief loss of consciousness with this event, as you saw. He has 2 hours of amnesia, so he has no recollection from the point of being hit for 2 hours later. He's in the hospital. He was spine boarded, taken to the hospital. CT scan was unremarkable. He rested, quote unquote, and then so he rested for a whole week, kind of took naps, didn't go to school, stayed away from computers, all that kind of stuff. And then he goes back into an engineering curriculum at the U.S. Naval Academy, it's not easy. And he starts doing his schoolwork, and everything is worsened. He's getting severe frontal headaches. He's feeling extremely tired. He's not able to grasp the concepts in his math class and science class. And really is also exhibiting a lot of anxiety, a lot of emotional changes because he realizes he can't handle the U.S. Naval Academy curriculum. And this guy who's going to be drafted in one of the top rounds of the National Hockey League, his career is now in jeopardy because of what he's feeling, So there's a lot going on for this kid. He goes to the team physician of the Naval Academy, and basically, they actually took him out of school for the remainder of the year. This happened in the fall, and they said, go home, recover, and you're going to miss school for the entire year. You can't handle the curriculum. You're going to fall behind. You can't play hockey. Go home and rest and recover. And so there's no instruction to this kid about how to get better. There's no instruction about any parameters around rehab. And this is a while back. So, and this poor kid, he's going through a lot with this. Basically, he was told to rest with no physical activity. So that's the treatment that's given to him. He had heard of our program through some of our work with the other NHL players, National Hockey League players, and so he came out to Pittsburgh to see us. I mean, I saw him 6 weeks after his injury, okay? Here's his helmet, and you can see that it's, broken, which means the force was pretty significant. And here's him at the time of his injury. Now, if you actually look at this individual, believe it or not, I was preparing this case, and I can actually see the problem without even, I put up this picture, I'm like, oh, there's the problem. And anybody in the audience want to share with me what they see and what they think they're seeing relative to what the problem is? Yeah, which eye? His right eye, exactly. It's an exophoria. So at the time of the trauma in the emergency room, if this had been recognized and treated, the problems with this kid would have been circumvented, okay? But that's kind of where we're at with concussion management. There's nothing in the international consensus statements explaining that there's different types of concussions. There's nothing in the international consensus statements talking about how you evaluate this, how you treat it, how you rehab it. This is an individual whose life has changed as a result of this injury and is miserable when I'm seeing him in clinic 6 weeks later. So basically, this case, importantly, really involved only one problem. This is not that complicated of a case. This is complicated when you see all of this. This is not that complicated when you see this. It's going to take a while to treat, but this kid was fortunate that that was the only thing going on from his injury was that right eye exophoria and ocular difficulty. So when I saw him 6 weeks post-injury, again, he was convalescing at home, he was taken out of school, he was not working out, and not surprisingly, fatigue levels were 8 out of 10. He had this really severe frontal headache, difficulties with focus. Focus could mean someone's thoughts are racing too quickly, or focus could mean when he looks at something. In this case, when he looked at something, he couldn't focus, literally, because his eyes weren't working well. And he obviously had a lot of irritability, concern, and sadness, which is not a byproduct of the injury. It's a byproduct of the way it was treated and a byproduct of all this means to the kid as it relates to his U.S. Naval Academy career as well as his hockey career. So there's a lot going on. And let alone when I saw this kid, the first question out of the parent's mouth was, is he going to have long-term damage down the road from this? And, and the mom was freaked out about the whole long-term issues because her son is not the same. He's not interacting with others. He's very internal. He's very anxious. He's not in school. And the mother could only focus on, does this mean he's going to end up with long-term, permanent brain dysfunction? It's not a good place to be mentally. So, in learning his case, we learned that the headache and fatigue was increasing with reading and computer work. Here's our evaluation at UPMC. We do a good interview. We do, neurocognitive testing. We have them see Ann. We have a full-time exertion person. So when someone comes and sees me, they're going to have appointments all day long with our practitioners. And at the end of the day, they're going to get a treatment program. They go home and do that treatment program. And that's all done in one day. So when we evaluated him, importantly, now you understand the VOMs, his smooth pursuits, saccades, VOR, and VRMS and balance were all entirely normal. There was no symptom provocation whatsoever. Even though he had a convergence insufficiency, when he moved his eyes, he wasn't getting headaches. When he did his VOR, he wasn't getting headaches. His VMS wasn't getting headaches. His vestibular system was actually working perfectly normally because what we do is we actually put him through a very detailed workout where we do dynamic movements, and he had no symptoms at all working out. So he had not worked out for 6 weeks. We put him downstairs. He worked out, and he was like, oh, my God, I feel so much better. Just working out was starting to increase, deflate the mood stuff. And then at the end of the day, when we said, this is what's happening, and this is how we're going to treat you, and yes, you're going to get better, his mood really came together. When we evaluated him, the only thing we were seeing in our entire evaluation was a 22-centimeter near point of convergence. And Ann, you want to briefly talk about, let me do a couple more slides and I'll have you speak. But here's his VOMs. You can see, at baseline, he had a 3 headache out of 10, 0 dizzy, 0 nausea, 0 fogginess, and none of these tests, with the exception of near point of convergence, increased symptoms. And then we have a measurement of 22, 23, and 26 centimeters. You do 3 trials on near point of convergence, and 5 centimeters is normal. He had a right exophoria at 22 centimeters. And here's a video I'll show you that in a while, actually, I guess. But here's his impact data. Now, when you look at visual oculomotor dysfunction, impact picks up best on it with reaction time, okay? But the reason these other two scores are impaired as well, it's interesting, but you're gonna see here's his baseline. These are percentiles. So this means that 4 out of 100 guys who do better than him 27 out of 100 do better than him, and then et cetera. But you can see post-injury, see how those scores are in red? That means it exceeds reliable change. We built in standard error of measurement into the test, so if they fall outside of normal limits, the score is bolded for you. Bold means you have an abnormal finding on the test. That's why baseline testing is so important, because we have a normal baseline before you ever had an injury. This is in post-injury. If you have 2 or more scores in bold, there's a 90% chance recovery takes more than 2 weeks, by the way. We actually have cutoff scores in impact, where if you have a score that falls below a certain cutoff, there's a 90% chance of recovery taking more than a month. So we have prognosis built into this, et cetera, et cetera. If you understand how to use it, it's very helpful. But you can see he's obviously not doing well. So what we did at this point, and I guess I'm going to show you a video of his eyes later, but what we did at this point is we started providing some vision therapy exercises. And Ann, why don't you walk through how you would have evaluated this? And remember, Ann's seeing him the same day I'm seeing him. So once I evaluate it, I go downstairs, I say, Ann, I think this kid is all oculomotor. Why don't you look at the vestibular stuff and tell me if you think it's normal? Let's look at the oculomotor stuff and start setting the stage for physical therapy. So go ahead and take it from there.
This is on, good. So, the VOMS is the beginning part of the screen, and that kind of picked up that he had that problem with convergence. We're going to look at things a little more in detail. For those of you that do this stuff, there's more in-depth testing you have to do, like cover testing and ocular alignment testing, and you have to look at accommodation along with convergence. But once we identified that the real problem was that near point of convergence, we wanted to kind of give him and create things that would have him use and recuperate that convergence, that near point of convergence. And as I said earlier, this works. I mean, there's great literature. There's a Cochrane review that showed that convergence exercises work. So I think what you're seeing in that picture is like an example of a convergence exercise. Again, very low tech. Remember, we weren't going to be able to keep seeing him. He lived outside of our area. He was going to go home and do things. So that's a Brock string exercise, which is basically just training somebody to use their eyes together at different points. That pencil push-up exercise that I showed you earlier is also a good one. There's a whole cadre of those types of activities and exercises that you can give patients to do. You need to know what you're doing, but they're very low tech. Now, in his case, I think we also had him get a computerized program because again, we weren't going to see him. We wanted him to really work. This was his only problem. So there are computerized programs that are nice because patients will do like a video game exercise for a little bit, and the computer program will actually advance them along nicely. There are a few platforms, I don't know what's available here, but in our world, it's the HTS and CVS programs that are out there. But we did that in conjunction with those exercises, and then all of the other instructions that are listed up here, we had him do, which is re-engage socially, re-engage activity-wise, and then start to take what he was doing with the vision practice from the exercises and put it into daily activities, like start getting on the computer and doing visual work, start reading so much each day, start doing things that were mimicking the visual activities he would have to do in school.
And yeah, the minute he heard that he could work out and skate, and we allowed him to skate the next day after seeing us, he was so excited. And then he was like, okay, I can do these therapy exercises. He had the HTS program, the computer program. It takes about 10 weeks to complete. It's a very sophisticated program. He did that program. He worked out, he re-engaged socially, and I said, look, you're going to get back to play. You're going to be safe. Everyone's going to be cool. And once he started doing that, things got better. Now, here he was. This is his second evaluation 5 weeks after starting vision therapy. So he went from 23 centimeters to about 9 centimeters. 5 centimeters is normal, but if you can play that video. Watch his right eye, about 9 centimeters right there.
You can see it start to go. Keep looking at it. Okay. All right. Tell me when it gets back to 1 again. Okay.
And so initially he was 23 centimeters. He's at 9 centimeters there. I saw him like 5 weeks after he started the vision therapy program. He's doing great. He has 0 symptoms now except headache when he works on a computer, and he's a little tired at the end of the day. But he was skating fully social, excited. He was signed up for his classes again back at school. I called the team physician. I said, look, this guy's going to be fine. He's going to be able to play hockey again. He's going to be able to get back to school. And he finished his vision therapy. We saw him 10 weeks after starting the vision therapy. His near point had gotten to 4 centimeters. Here's his impact data. So you can see the second time I saw him after, you can see the only score that was impaired was reaction time, which is what we expect to see with a convergence insufficiency. Anyone want to guess why his visual motor speed score was so poor the first time if there was not a vestibular problem? The reason why is because it had not been activated yet. He had done nothing. And you have to activate that system to get someone better. So if you really just did the international consensus statements on this case, technically this kid would have never gotten better, right? Because you can't do anything if he's having symptoms. It just doesn't make a lot of sense as it relates to when you start to identify what is actually happening and how you treat those problems. Here is a video, very brief video of him talking about the experience and what he felt going through the experience. And keep in mind, before you play the video, this kid got back to hockey. He actually ended up getting drafted. He ended up finishing and graduating from the U.S. Naval Academy. He is a great kid and has had no reoccurrence of concussion since this injury, and really ended up is having a great career both as a human being and as an athlete. And it was really, he's a nice, wasn't he? And he was a very nice kid. But you can play the video real quick. When I first saw you, what were the things? How did our approach? What about the approach was effective in terms of getting you through this?
Just knowing like exactly what was wrong and like having a set thing of what to do rather than just just sit in a room and like wait for it to go away.
That doesn't help anyone, does it?
Nah. That was one of the biggest things is just like when you're just sitting there waiting and nothing's getting better, and then you just feel like when is this going to change, and then. When you see even just like a little bit of progress, it helped out a lot. And
What therapy was the most beneficial to your recovery?
Definitely vision therapy.
How long into that did you start feeling like, oh, medical man, this isn't working?
Like probably a couple of weeks into it, and then I wasn't getting the headaches as much.
So that's the case. How much time do we have to? Do you want me to stop there, or do you want me to do another quick case? I can do another quick one if no one's... You want me to do another? Okay. And this one's very subtle, but I thought it would give you an idea of how subtle this can be. And again, it's a hockey player. I apologize. I wish I had a hurler or something. I don't. But basically, this is a 14-year-old male hockey goalie. If you think all I see is hockey players, that's not the case, I promise. But this is a hockey player as well, although we are busy with hockey right now back in the United States. So quick overview of this case, 14-year-old. He was treated for 2 distinct injuries by our program. The key points before showing you the case is this demonstrates how important it is to receive multidisciplinary care, multimodal assessment. It's going to show the importance of having a baseline on someone as it relates to understanding if there's still problems or not. It's going to talk about how dynamic exertion is so important to look at when you manage concussion in relation to just doing like aerobic activity. You actually need to move people dynamically to see if there's any lingering sequelae or problems. And also it talks about the patient's risk factors. Per Anthony's lecture, that risk factors do play a very strong role in where to look, and what actually happens to these kids that go through this injury. So let's go through this. I'm going to go through this pretty quickly, hopefully. So the first injury we treated him for was in November of last year. He's a goalie. He was struck in the helmet by a puck, and he saw 6 days post-injury. There was no loss of consciousness, no amnesia, no confusion at all. The only symptoms he had initially was headache and dizziness, fogginess, and nausea. Now, I had a really good conversation with one of the team physicians here in Ireland at the break. Can you raise your hand? Where are you? Yeah, up back. You're near the Galway area, I believe, right? And you have been doing this stuff for a long time and sound very, very good at what you do. And this is not easy to evaluate. The sideline stuff, and I didn't mean to marginalize how difficult it really is earlier. I'd like to change the conversation, or I'd like to at least add conversation that it's not just on-pitch management, but it's treatment that we got to get to. But the on-pitch stuff can be very difficult as well, and I didn't mean to trivialize that. This is a kid who basically played for 20 minutes beyond having symptoms. That happens all the time. And even though we try to tell kids to come out of play when they have a headache or dizziness or nausea, they don't know to do it. They've never been through this. They're not educated on it. And by the way, when you have a decompensated vestibular system, you actually may not feel it initially, but you may feel it on the car ride home because that's a very demanding vestibular environment. You may feel it when you start moving dynamically. You may feel it on the bus ride home. Okay, so let's not trivialize how that is a difficult on-field thing too. And this kid played through 20 minutes of symptoms. Fortunately, he didn't get hit in the head again. But he did, after this, return to hockey and basketball activities before seeing the clinic. And then that provoked dizziness, nausea, and headache. This kid had no idea he was really concussed at all. And then when he went back to activity, he'd feel it. And he finally told the athletic trainer, and the athletic trainer pulled him out. And we saw him. He took several days off of school after seeing his pediatrician, but then went back to school the day before we saw him. Symptoms worsened. He has a history of motion sickness, which tells you what's going on here. It's a very vestibular. There's no family history of any problems. So when we first saw him after that first injury, not surprisingly, fogginess, dizziness, headaches were all being provoked in busy environments like the cafeteria. He was light and noise sensitive, had some sick to the stomach. The primary trajectory is vestibular, secondary trajectory is migraine. The migraine is the light and noise sensitivity in the morning type of symptoms, and the vestibular dysfunction is pretty apparent. All we did for treatment in this case, and it was very successful, he had 3 sessions of vestibular therapy with Ann. We put him back to progressive dynamic exertion. He passed an exit test. I'll have Ann talk about that in a little bit. And then he was cleared 1 month after his injury after 4 clinic visits. So good outcome. He's back playing, but that history of motion sickness makes him at risk for more injury. Now, he's normal after we clear him. There was no residual problems. He went back to play. Everything was cool. This was his VOMs. After the first visit we saw him, you can see that he had a little provocation in VOR. Everything else was normal. His near point's normal. See the difference in the cases? And this is him when we cleared him 4 weeks later. The VOMs is totally normal. And this is his impact data. Now, I don't have a baseline before that first concussion. This is his injury data when he's recovered from our treatments after the first injury, which we use as a baseline, okay? And you can see here, this is post-injury 1, I'm sorry, and this is post-injury 2, 3, 4. So this is where we clear him, and this is where he was when we first saw him after the injury. And you can see, you know, not surprisingly, the only area that exhibits improvements is visual motor speed. A standard deviation on that scale is 5.5 points, and you can see that he was abnormal. The 4th time we saw him, you know, he's at the 70th percentile. All his data is normal, but this is the one domain that had reliable improvement over the course of our treatment, which makes sense when you think about vestibular impairment and motion sickness and all this type of stuff. Everyone understanding that, how to look at it? Okay. So basically, that's where he is when we clear him. So then we end up seeing him 9 months later. He comes back into clinic. And remember, people with a history of car sickness are more likely to get concussions and have problems after an injury. And sure enough, he's playing hockey again. He gets hit in the head by a slap shot again to his mask. He actually had damage to the cage of the mask, given how severe how fast the shot was. There was, again, no loss of consciousness, no amnesia, no confusion. But he did have immediate dizziness, slow and wavy quality, which is brain stuff, right? Mental fogginess and nausea. And at that point, because he went through his first injury, he's like, oh, I've had this before. That didn't go so well last time when I kept playing, so maybe I should take myself out of play this time, right? Smart move, because and this is a study, we just published a study where if you continue to play through your symptoms for on average 22 minutes, or 22 minutes, you play through your symptoms for 22 minutes, your recovery time is 44 days. If you come off the field immediately, your recovery time is 22 days. Even playing through this a little bit is going to change your outcome, especially when it comes to vestibular dysfunction. Okay, so even though it's not easy to sort of recognize, and it's usually symptom-based stuff, if you teach athletes that you get out of play quicker, you get better faster, that would be a kind of a nice little cultural shift there, wouldn't it? But basically, he had all the symptoms of vestibular dysfunction. He came out of play immediately. But due to his, and then on the car ride home, not surprisingly, he gets a bad headache. That's the vestibular stuff. If you ever have a patient get a worse headache in a car ride after an injury, think vestibular. Cafeteria getting headaches, think vestibular. Movement, dynamic movement, think vestibular. That's what's going on with this kid, which makes all the sense in the world. So we end up seeing him 2 days later from this injury. And because he took himself out of play, he said he was basically completely asymptomatic when I saw him 2 days post-injury. And think about how different this is than the first case where he was not asymptomatic. He had gone to school the day prior without any symptom provocation. He had engaged in some mild exertional activity, had no symptoms. We administered impact and did the VOMs. Now, even though he's telling us he's completely asymptomatic, I want to show you this. So this is his neurocognitive data. 2 days after this recent event, here is where we cleared him. Normal change in this instrument, anything more than 5.5 points is considered abnormal. He's a standard deviation and a half off of normal, whereas the other scales are completely normal relative to his new baseline. See that? This data point is definitely abnormal compared to here. So even though he's telling you he's normal, he's not normal. On the VOMs, he did not exhibit any provocation of symptoms whatsoever on VOR or VMS. But because of that neurocognitive deficit, I'm not going to put this kid back to play. Okay? So even though he's telling us he's normal, I'm not going to put him back to play because there's an abnormal finding. We don't put kids back to play until this is gone, 100% gone. So 2 days later, we actually wanted him to start to re-engage in full non-contact exertion. Remember, the way you treat a vestibular problem is by activity. So we wanted him to get on the ice, start moving, start doing things aerobically. We did not think he needed vestibular therapy because this was pretty mild. We just wanted him to work out, but without contact. And then basically, no academic accommodations. We were going to see him back probably 4 or 5 days later to see if his impact data had improved and see if the athletic activity kind of cleaned up the rest of this vestibular problem. We see him back on 9/11, and you can see here, so 3 days later, he's still not normal compared to baseline. His symptom score is 0. All the other data points are completely normal. Here's his VOMs, normal. So what we did at this point is we administered a test called the exit test to see if we could pick up on if there was any problems at all working out with dynamic movement. And you're going to see here, this is the test. Do you play that left video? This is the only test where he became symptomatic, was really dynamic ball toss stuff. That's not him, by the way. That's one of our athletic trainers. But basically, that's the test where we picked up. He got dizzy doing that. And Ann, you want to talk about the different, this is a pretty subtle presentation because, the VOMs is normal. And if you just did the VOMs and didn't do neurocognitive testing, we would have put this kid back to play. But the system is not recompensated. So.
Yeah, I mean, if you look at what he had technically met criteria for return to play. He had been back to full activity. His testing was good. But if you look at the activity that he had gone back to, he did yoga, and then he did one-on-one basketball. So he was just shooting around.
He did a pond skate as well, so he didn't do heavy dynamic
skating. He did nothing where he had actually been forced in an exertional way to move. And without that, you haven't really stressed their system well enough. And so, I think that we have developed this test. Gosh, I think it's probably been about 7 or 8 years now.
Yeah.
But we developed it specifically because we had patients like this who we actually would clear, and they would end up coming back still being somewhat symptomatic. They wouldn't have had a new injury. They just noticed that as they got back to all of their full activity, they still weren't right, or they had a return of symptoms. And since we started doing something, more of a formalized exertion protocol, which isn't truly just about putting somebody on a bike, putting somebody on a treadmill, but it's making them move in dynamic ways, in ways like this, that we're picking up on these problems, we're making sure we address them, and then we're getting them back to play.
Yeah, because if we put this kid back to play and the vestibular system is not completely recompensated, he had a prior concussion eight months ago, and this one, he's got the history of motion sickness, it's going to take very little biomechanical force to set him down a pathway where it could affect his athletic career. So you got to do this correctly. But knowing how to look at it, knowing how to test it, knowing what it means, it's a little convoluted if you're not at a certain level of understanding how to look at concussion. And that the exit test that we're talking about here, I think having a standardized return to play exertional test is really important. So we ended up prescribing a workout program to him without contact that actually incorporated some of those real dynamic movements. He did those for 5 days. He came back to see me. So this is 12 days post-injury after that second injury. We put him through high-intensity dynamic exertion. We redid the exit test. Everything was normal. And there he is. This is where he was when we cleared him in 2016. Here's where he is at post-injury 3. This kid is a really nice kid. He went back to hockey now. And here's his VOMs. And basically, everything is totally normal. He's back playing hockey and everything's cool. But, the summary and takeaway points, the history of motion sickness predisposed him to have vestibular profile problems. You can see the difference in this case versus the ocular case. It's totally different. The course of his previous concussion informed how we managed the next one, and we had that baseline from when he was cleared the first time, which is really good. Self-report is limited. To your point up back, the team physician I spoke with, it's hard. This kid played through his first injury. It's going to happen at times. We like it not to happen, but it does. Just the way this works, it's not like everyone has a cast on their head with this stuff, right? It can be very subtle. But understanding the specifics of the data and how you look at this stuff is important. And then also knowing how to rehab it and using the right exertional stuff and the right movement stuff is so important to the health and welfare of these kids moving forward. So with that, that's the 2 cases I wanted to present, and I think we're going to have Aoife present one of her cases as well. Thank you.
Mickey finally got my name right. When I spent a week over in America, he spent the whole week going, what? How do you say that? So I used to be EFA everywhere all over the clinic when I was there. My case is not an ice hockey case. I work in the bonds with Dr. Niamh Lynch. We run the pediatric concussion clinic. There's 5 physios involved in it, and then Niamh is our primarily referral clinician, but I'll talk about it later on in my next talk. So the case study I have is actually not a sports case study, because often when as GPs, you mightn't see someone from a sporting event, it might be someone who just fell. So it was an 11-year-old boy. He fell in his schoolyard, he slipped on leaves, hit his head in November, and he presented to us in March. He doesn't remember the fall, he doesn't remember the evening afterwards, but his school and the mum reports dizziness and headache at the time. Now, from all the research, it shows that if you have amnesia at the time of the event and you have dizziness at the time of the event, it's a predictor of a longer concussion, and your recovery time is going to be delayed. He had no loss of consciousness, and a big thing, everyone thinks if you've lost the consciousness, it's a poor predictor of your recovery. It actually hasn't been proven that way. It actually shows sometimes loss of consciousness is actually a protective mechanism, because you're taken off the pitch, you're minded, and you actually recover often quicker than someone who actually didn't have a loss of consciousness. So it's something to just be aware of. He went to his GP and he was referred to A&E, and no scans were required because they deemed he didn't need anything. And he took 2 weeks off school to rest. All seems great. He then went back to school after 2 weeks, and he was reporting a lot of headaches, and this was ongoing until he came to us in March. So we kind of do a subjective and an objective. We're not as lucky as them in Pittsburgh. There is 2 of us in the clinic. There's a physio, there's a doctor. Physio does a lot of the stuff, and then Niamh does then all the neurological testing for us, so she'll do all the red flags. So we're a bit smaller than Pittsburgh. So we look at outcome measures, and as being a physio, outcome measures are important. So there's a few of them. The one we did with this child was the dizziness handicap inventory scale, and it looks at just his symptoms and what caused dizziness. We looked at previous concussions if he had any, and he didn't. We looked at his symptoms, and we look at the mechanism of injury. And then objectively, we're looking at cervical spine, ruling out any instability, at C0, C1, looking at range of movement. You're doing your VOMs, and we're looking at the balance screen as well with him. So in our subjective, no history of concussion, his first ever episode. He was complaining of headaches, photophobia, phonophobia, and blurry vision. especially with maths. In school, he was having great difficulty with maths in school. He had poor concentration. He didn't want to play with his friends, and hurling was his big sport. He had difficulty turning his head when swimming. I said he had difficulty with maths. He had fogginess, he had irritability, and he wore glasses, but that was a long-term issue, and we'll talk about that in a second. So looking at that, you kind of think, oh, okay, he's moving his head, might be a cervical involvement, but then going back to trouble with maths and he had headaches, you're thinking maybe there's an ocular problem. So objectively, we found when we assessed the neck that he had cervical stiffness, he had trigger points in his sternomastoids, his scalenes, his splenius capitis, and his upper traps. He had tenderness and palpation at C3, C4. He had no instability, which was great, and he's testing his upper cervical spine, and he had no red flags. His dizziness handicap scale showed a score of 34 out of 100, which shows mild to moderate dizziness. He had no ocular malalignment, which is, when Mickey talked about his first case, it was an ocular problem, and the kid had an exotropia. You can get ocular problems and not have, actually, when you're looking at the kid, that he didn't have an exo or an esotropia. And his best, it showed on firm surface, he had 7 errors, on a foam surface, he had 19 errors, which is quite high for an 11-year-old boy. So this is his VOMs. He came in quite symptomatic, so he was scoring 5 out of 10 on his headache, and he had 2 out of 10 on his dizziness. They did increase as we went down, and you can see his headache kind of only went to 6 when we did the ocular ones, but when we did 1 or 2 of the vestibular ones, they went up to 4 or 5. But the big thing is to look at his convergence. So as Mickey said, his convergence is to be less than 5. So we tested him with glasses, and I tested him without glasses. And it's something I always do if someone has glasses, because kids often don't wear glasses in school, because pride is a big thing. So we test him always both ways. So it showed that he had convergence of 37, 39, 38, so kind of an average of 38 centimetres, which is way above the average. And even with his glasses on, he had an average of 25.3, which shouldn't be. His accommodation also showed that it was off. It should be less than 15 centimetres, so he had 22, 24, 25. And actually, it was funny, if you did 10 of these tests, he actually fatigued more and more, and his numbers ended up getting quite big. And again, his VOR, his vertical, and his VMS score, all were giving him his headache, and all giving his dizziness. So you're thinking, oh, is it ocular, is it vestibular, what was going on? And also then he had cervical problem. And as Mickey mentioned in one of his talks, you can actually develop sometimes little bits of each of the subtypes of concussion. So with this child, he ended up being an ocular primarily was his problem, but he did have vestibular problems, and he also had cervical troubles. His ocular one, there was the one that was driving his symptoms, so it was the one we looked at, and it was the one we started to treat, but we also did some hands-on therapy for his cervical. So what we did, first of all, sleep hygiene. It's really important with people with concussion to get their sleep pattern back to normal. So giving them advice, no napping, going to bed at the right time, no phone before you go to bed at night time. His mum actually had a really clever idea. She used to turn the Wi-Fi off at night time, so when he's going to bed, he couldn't use his phone. I thought it was really clever. So I tell all the teenagers now with the parents turn the Wi-Fi off. We did soft tissue techniques and manual therapy to his cervical spine, gave him a few stretches, pencil push-ups for his ocular movement. So we gave him pencil push-ups, we gave him Brock string exercises, we gave him eye charts because he had difficulty looking in school, looking at his copybook, then looking at the board, looking at his copybook. So we gave him 2 eye charts, one close and one far away, and he had to read every second number or every second letter off him, and I got him to converge, diverge, converge, diverge really quickly. We also gave him, if you actually Google eye exercises, there's great little ones you can get for apps on your iPhone. They're free as well, which is even better for the kids. So little ones finding like follow the snake, like the old-fashioned snake in the Nokia phone used to be a great one for them. But follow the snake, also looking at find the 9 in a box of numbers, so different exercises you could give at him. Then concussion advice, because the mum was really worried. He was 11-year-old, she'd heard all the hype, and just telling him, look, it will work, it will be better. And then in the end, we did an exertion test before we cleared him. So in his final review, he only took 3 treatments as well, which was really good. You can see in his final review, his convergence was off still with no glasses, but it was a long-term issue. He'd always worn glasses. So when we retested him with his glasses, his convergence was in normal limits, 1.6 centimetres. His accommodation also had come back to really, really good levels. As I said, less than 15 is normal limits. Again, 2.16, 2.66 he had. He had no symptoms. He was back playing. out with his friends. He hadn't gone back to training yet with hurling. His best score, I showed 2 errors on the firm surface and 3 on the foam. Now there was slightly, still he had 1 or 2 errors, but he's an 11-year-old. He wasn't the greatest in terms of strength and in controlling him, and he was going through a growth spurt as well, so he didn't have great stability. And you will find with adolescents sometimes, if they're going through a growth spurt, they won't have the stability in their quads or their hamstrings to keep themselves nice and stable. So they are allowed maybe 1 or 2 slight errors, but if you compare it to what he had before, he'd really come down. His handicap scale was 0 out of 100. He passed his exertion test. He'd no neck tenderness and had full range. He had no symptoms for the past 3 weeks, and we had him out playing with his friends, pucking about, going through drills, doing running drills, doing pickups, doing catch and hit, doing free taking. So he'd done a lot of non-contact stuff before he came back to us. He'd gone back swimming again, and he'd no problems, and he'd been running for 20 minutes every day, again with no issues. So once he passed his exertion test, we actually discharged him from physio, and we haven't seen him again, which is a great news. So that's just like literally in terms of, it doesn't always have to be a sports, it can be just a little fall in him. And in our clinic, when we show our stats later on, some of ours actually aren't even sports, so we come to our clinic as well. That's it, thanks.
Aoife, did you get him active after the first evaluation?
Yes, we got him back doing out the back. We had him just, initially when he came to us, we had him on the bike, just starting off to see what he was like, but then he was fine with that. So we got him out the back and just got him literally, like I said, hit the ball off the side of the wall, again, non-contact, where injury was reduced down. I then said he could go cycling with his mum, but in a nice quiet area. So from day 1, we got him doing exercise. Now he had been back in school, so he used to avoid PE, but I told him that he could go back to PE once it was non-contact again.
My suspicion in looking at that case is that active approach changed the course of this. I think anxiety was probably playing a fairly significant role with him, just looking at how much he improved, quickly he improved with the oculomotor stuff.
He is amazing. Between his first and second treatment, he went from 38 centimetres in his convergence down to 12 centimetres in his and there was a 3-week, just really had left 3 weeks off from his eye exercises. He was a lovely, actually happy kid. He was a bit anxious that he couldn't go back and play sport, but in terms of everything else, he wasn't worried about school, and his mom actually wasn't that worried. She was all proactive for him, involved in everything. So even though he might have had a small bit of anxiety, it wasn't the main one we found from talking to him. It was more his ocular system.
Well, you guys did a great job. It's a great case.